we do capture a lot of them in the first 3 years of life. As you know, that we get a lot of visits: 1 month, 2, 4, 6, 9, 12, 15, 18, 24, 30, and 36. That's a lot of visits. So this, I think, is the prime time when they are establishing good relationship with the providers. This questionnaire can actually be administered at a pediatric office to get the help they need. I think most of the times parents don't know where to ask for resources, and they did not think that a patient-centered medical home is the place to ask.
Welcome to the Health Pilots podcast, presented by the Center for Care Innovations. This podcast is about strengthening the health and well-being of historically underinvested communities. Every episode offers new ideas and practical advice that you can apply today. What happens when healthcare shifts its focus from "what's wrong with you" to "what happened to you"? And how does it impact pediatric care delivery? To answer this and to share with us deeper insights into the work, Health Pilots is featuring care teams from the Resilient Beginnings Network, a Center for Care Innovations program dedicated to advancing pediatric care delivery models that are trauma and resilience informed, so that 100,000 young children and their caregivers have the support they need to be well and thrive. Facilitating this conversation with the team we have today is Dr. Dana Long, Primary Care Pediatrician and Clinical Director for the Resilient Beginnings Network, or RBN for short. Hear the team's journey through this program, the valuable lessons they've learned individually and as a care team, and the unique transformative impact of the Resilient Beginnings model on patient care. Find out what it means to provide care in which all parties recognize and respond to the impact of traumatic stress and resiliency factors on children, caregivers, and service providers. Today's episode features Bay Area Community Health, which was formed off the strength of Southern Alameda County's Tri-City Health Center and Santa Clara County's Foothill Community Health Center during the middle of the COVID-19 pandemic in 2020. Bay Area Community Health, or BACH, brings more than 70 years of combined service to an area that stretches from Union City to Gilroy. They serve more than 100,000 people who rely on high-quality healthcare services regardless of their immigration status, ethnicity, disabilities, or ability to pay. In this episode, you'll hear our guests speak about adverse childhood experiences, known as ACEs, as well as the screening tool to address ACEs called Pediatric ACEs and Related Life Events Screener, otherwise known as PEARLS. For more information about these concepts and tools, please visit our episode's show notes. With that said, I'll pass it on to Dr. Dana Long for our conversation with Bay Area Community Health.
Hi, I'm Dr. Dana Long, the Medical Director of the Resilient Beginnings Network. And today I'm here with two amazing members of our Resilient Beginnings Network Collaborative. Can you please both introduce yourselves, say your name, and what your role is at Bay Area Community Health?
Hi, my name is Melissa. I'm the Pediatric Care Coordinator for Trauma-Informed Care.
I'm Dr. Sheshadri, a pediatrician by training and clinical director at Bay Area Community Health.
Thank you so much. So when both of you think about systems of care delivery that are trauma-informed, can you really walk us through what it looks like on a day-to-day in terms of how you approach patients at the Bay Area Community Health Center and what patients' experience is when they come in contact with your clinic?
So initially, we did not have anything in mind like trauma, resilience, or informed care. So at that time, we did not have the term adverse childhood experiences or anything like that. But we were seeing the impacts of this in classroom, on the street, in our jails, and on the news, resulting in significant cognitive delays, learning difficulties, as well as delinquent behavior, bullying, physical fighting, dating violence, and weapon carrying. So at that time, our CEO, Dr. Page, would talk about three things before we actually introduced this. And those were the three missions. And he said about quality, community, and respect. So what Bay Area Community Health stands for the quality is everyone deserves to enjoy quality healthcare, no matter their ability to pay. And for community, by listening to our community with humility, we gain strength, purpose, and partnership. And he would talk about respect. So all who enter our doors, like patients, staff, community, and partners, are heard with an open mind and valued for their unique strengths. So that's how we started, before we had all this trauma-informed care and so on, because our patients have suffered trauma for generations due to historical racism, structural inequities, and trauma related to immigration. So becoming a healing organization with a trauma and resilience-informed pediatric care model became our vision. So with the coaching received from your team at Resilient Beginnings Network and Center for Care Innovations, our vision strengthened. And on a day-to-day basis, I think, Melissa, you can talk about what exactly we do with the patients, how we screen them, and so on.
Registration staff reviews patients' records to determine if Pearl screening is indicated during visit. Staff provides Pearl's tools to the caregiver and or to the patient that's 12 years to 18 years of age. Medical assistant transcribes ACEs score into the EMR. Provider reviews ACE scores, treatment plan. Provider documents ACE score, billing code, and treatment plan, follow-up in a visit note.
So initially, our plan was to standardize and systematize the workflow for the screening on a day-to-day basis and to document it. So this was our very first objective in our day-to-day program when this was first started by the then pediatric director, Dr. Puri. And now I think we've come such a long way from there. So I would like to give a shout out to our ITIS team. So when we do log into a patient system or onto a chart, it does pop up on our electronic medical records that we have to remind our staff to screen the patients, which is our first step in becoming a healing organization, to find out our patient needs. So this pops up and it says, hey, let's administer this questionnaire. So that's what we do as our first step. And that's what we did with you all in our first year at Resilient Beginnings Network Collaborative.
Being that you're a clinic that is relatively new, starting essentially during the pandemic, how did you guys first start to think about, well, we should screen for ACEs and respond? And what was the startup like for you in terms of how did you approach staff and start to do the training that's necessary even to initiate screening?
That's a good question. So we were two different organizations when we first started, although we have a lot of history of decades of each of the organizations. So we also were on two different electronic medical records. I remember Tri-City being on NextGen and we were on ECW. And then we were able to change over to Epic and eventually merge onto it. But we were giving out paper questionnaires and the parents would fill it out. And I think this role of Melissa was created for this. This is only in, we call ourselves Bay Area Community Health North for Alameda County and Bay Area Community Health South for Santa Clara County. So this role or title of pediatric care coordinator that Melissa does is only here in our Alameda County. So we are still trying to carve out a role to have a separate person doing this in Santa Clara County at this time. The medical assistants are helping with that, with behavioral health care coordinators, but still like this particular role of her was created for this. And again, I would like to give a shout out to CHCN for having given us a grant for a pilot pediatric care coordinator project, which has become a huge success. And they're going to continue funding it for the next 4 to 5 years.
Melissa, if you can, I do think your role as a care coordinator is so very important. And I do want to give you a chance to talk about what is a day in the life look like for you as a care coordinator at Bay Area Community Health.
Well, a day it's, helping patients, supporting the clinicians, with all these referrals, BH referrals, ABA referrals, following up on all these positive ACEs, with the patients, getting them connected with, behavioral health, in referrals, following up, making sure that they're being connected. I mean, there's been a little challenge, sometimes, it's hard for parents to answer the phone because they're at work. So I always, try more than 3 follow-ups at some times because, I just want to make sure that they get the resources they need. I'm just here to support, it's been good that I've been able to support the providers and like the parents also, with their children. And, I think the main thing is just, getting all these parents connected to the services that they need.
Absolutely. What are the most common resources that you're referring families to?
We're referring for food insecurities. There's still housing. I'm still getting resources for housing, also for behavioral health. If I see, their scorings are high, refer them or have the providers refer the patients to behavioral health. And also a big one has been, the autism evaluation and also for ABA.
When you describe your workflow, I'm wondering if you can tell us in a little more detail what that workflow looks like for you.
So as the workflow, like we mentioned before, the workflow starts with the front desk. The screening forms, they're handed out to the parents. The providers also follow up with the screenings. They make sure that, the patients fill out the screening forms before they leave. There's a lot of forms that we give out, but we all, the providers are always good with this, the ACEs screening forms, that they make sure the parents don't leave before they fill out the form. If there's any positive ACEs and I'm available, I do warm handoffs in the exam room. I try to, help them as they're here. If I'm not available, I always, I always collect the screening forms and I follow up with all these parents. And just give them a call. I do my documentation. And, like I said, if I need to do any follow-ups, I, continue to call the parents, making sure they get connected. And then once they get connected, I close the loop.
So initially when we gave out the patient questionnaire and they fill it out, like how Melissa said, we got a workflow going, they give it back. And then the provider goes through this, finds out which are the adverse experiences or what needs the patient has. For example, let's say like the food insecurity or the housing insecurity. And we call Melissa, give her a warm handoff, and she takes it from there. So she looks up, which is called Find Help on Epic, on electronic medical records. And then she gives them the resources. During the COVID pandemic, though, we did not have all of these resources on hand, or when we first started, we did not have all these resources. So we would reach out to other organizations or like the community-based organizations to find out where are the food banks, what can we do at that time. And she would then call the patient and give them follow-ups. But then I think we've come a long way now where we can create a referral in Epic, which goes to her work queue station. And then she calls the patient and closes the referral loop, which we did not have 3 years ago. So patients would fall through the cracks, right? We were not sure. Did you already get to the food bank? Did you already get the legal help you needed? Or so on. So we've come a long way, but this is how we started.
It sounds like that you're screening for 12 and up. How did you guys come to the decision to start screening, starting with the teenagers?
We have been doing all ages, 0 to 18 years, during every single physical exam. For 12 and up, we do give the questionnaire for both children and adults, like the parents that they come with or guardians they come with. But for less than 12 years, it's just for the guardian. We have behavioral health clinicians who are taking care of patients about 12 years of age. And currently, as we know, there is a national crisis of shortage of behavioral health clinicians at this time. We are still trying to recruit somebody for less than 12 years of age, but we are screening those less than 12 years of age.
Wonderful. So to clarify what you were saying, Melissa, is that you hand the screen to the actual teenager if they're 12 and up, but you are screening starting at 12 months?
The patient, 12 years and up, 12 years to 18 years.
12 years to 18 years, we give it to both parents and patients. We start at 2 months itself, like every single physical exam that we do on the patient, we do give out the PEARLS questionnaire in the language that they need.
And then so you start at 2 months, and are you then doing it at every visit or is it annually?
Every physical visit. So we do capture a lot of them in the first 3 years of life. As you know, that we get a lot of visits: 1 month, 2, 4, 6, 9, 12, 15, 18, 24, 30, and 36. That's a lot of visits. So this, I think, is the prime time when they are establishing good relationship with the providers. And one of the parents actually said, we did not know where to go for our social determinants of health or like the socioeconomic needs. And that this questionnaire can actually be administered at a pediatric office for us to get the help they need. I think most of the times parents don't know where to ask for resources, and they did not think that patient-centered medical home is the place to ask.
Let's dive more into that response. Can you share, Dr. Shesh, more about what happens after you screen? What are the most common responses that you receive?
So I could give an example. So I've had some families where, father and mother are separated. Sometimes we would have been seeing these patients for, let's say, 4 to 6 months. We ask all the questions about social history and assume that we know these patients well. But when they are actually asked to fill out the questionnaire is when you get to know some real answers, because some families are private, some are shy, they want to keep it confidential, they just nod, they came in for a rash or some other thing, right? So they really don't want to discuss all their social issues. So most of the times it was the teens who spoke out about their parent being deported or immigration issues and requested counseling to process grief. So prior to this, they would just mention parents are separated, but sometimes we don't dwell much on the reason and we just move on to the next question during a physical exam. And the other thing that we also noticed was a lot of food insecurity and housing insecurity. Those were two big things that we noticed during the COVID pandemic. For example, I had a parent who did not know how to read or write, a single mom with food insecurity. She sold homemade food for a living. She came in with behavior concerns of school performance and defiance in the patient. And I have to appreciate the pediatric care coordinator, the wonderful teamwork, where mother was able to get the food bank numbers from the coordinator and able to pick up food. And very happy that this questionnaire that we administered was able to pick up such issues and help her. And Melissa was able to make appointments with nutritionists, specialists like behavioral health therapists for the mother, and provide written communication with pictures as to how to reach that appointment place, right? Like practical problems in life. Like mother could not read or understand Google Maps. So if I referred them to cardiology, she would write a little hard, put the number down or the place, tell her like how to go, directions, arrow marks to reach the place. And we had to find something close to her neighborhood. Or if I referred her to nephrology, like put a little kidney mark on there, like the kidney bean, and tell her how to go there. Also in the COVID lockdown and shelter in place, there was this kid, with food insecurity had eaten junk food, or which is less expensive, as we know. Some of the times, you can get a big bag of chips and soda for less. It's less pricey than when you have to buy a salad, right? It's a lot of process that takes to actually buy them all, put them together in a tasty manner. So now she was diabetic with hypercholesterolemia, and she's 8 years old, A1C of 7.8, and mother was provided the food pharmacy number. So we are doing a project called Food as Medicine, and through Recipe for Health, through our Alameda County, our county network, they provide free healthy foods to those in need. And after eating these healthy foods, her A1C decreased to 7 in about 2 weeks. The parent was extremely happy and gave positive feedback. She said something impactful, that she was never asked this question before and she was too embarrassed to ask for help, did not know, like I told you before, like where to go for this, who to ask about these things.
When you were first talking to the other staff there, was there any pushback or hesitancy about doing screening?
Yeah, absolutely. So initially, we went to acesaware.org website and we had to take a long course. So we were over 40 providers. It's a 2-hour course. So just, like the the barriers would be to actually block all of us, which is over 80 to 90 hours of work time to get this done. I actually had a few providers where they had their own adverse experiences growing up. So they said it's going to take us extra time. We have to process these too, as we have to go through this process, grieve, heal. They were able to talk to a couple of therapists and eventually finish it. And once certified, I think most of the times we as providers and also our staff are, okay, we're going to screen. Let's say it's positive, then what? I think that's where we get stuck. That's where we're very nervous. And like most of the other organizations who started with Resilient Beginnings Network and Center for Care Innovations was like, we screened, now what? Where do we find the resources? Now they are positive. So we need like a person, care coordinator like Melissa, to actually do the warm handoff, follow up. Otherwise, there was no point screening, is what most of the providers thought, most of the staff thought. And they were all trained in this with the course, the ACEs Aware course. And also, one other barrier that we noticed was insufficient time to discuss all of these positive scores. So we either have 30 minutes for a physical exam or 15 minutes for a short visit. So we had to schedule more visits to follow up. But this actually created a better relationship between the provider and better trust that the provider can take care of my kid's physical health as well as the socioeconomic issues as well. And we are very thankful for the role of Melissa, who follows up the patient very closely now till the referral loop is closed. And that was another of our objective, because initially we were all about screening and then it's positive, now what? So we had to make a list of resources. So we actually reached out to Alameda County and Santa Clara County to get a list of community-based organizations who can actually help us provide these resources. And now we actually, like I was telling you, we have Find Health on Epic itself. It's real neat. You put in like the zip code of the patient and it takes you to a list of things that you need. Do you want housing? Do you want school district? Do you want early intervention? So you can ask the parent, where are we at? Like, what do you need at this time? And we can, Melissa does this. She sends out she can actually fill out forms for them and follow up and submit it.
When you are responding to ACEs, talk to us about what are the typical responses? What's the most common response and intervention that you guys are providing?
I think most of the times when we actually started out, as I said, most of our staff are worried about what if it's a sexual abuse? What if it's a physical abuse? Where do we go? How do we follow up? What is the evaluation process? What's the workflow? What's my role as front desk? What's my role as a medical assistant? What's my role as a pediatrician? But like I said, most of what we found was food insecurity and housing insecurity. These have been the two major things that happened. And I think, although not listed as a core adverse childhood experience, since we were formed during the pandemic, COVID, I think, was a big community trauma. It was a lot of families got affected. And although COVID is not listed on the Pediatric ACEs and Life Events Screener questionnaire, it has exacerbated the ACEs in the vulnerable population that we see. How many of us will agree that when we ask if they're doing well and housing is stable, parents not. But when we ask them to fill out a questionnaire, we get the true answers. I had a single mom with 4 kids who lost her job due to COVID and shelter in place and was evicted in March with 3 special needs kids and was requesting family members if she can stay with them. And the teenager had actually filled out and said, we don't have a home right now. So we were able to provide resources for these patients. And the list of resources is also very limited because not everything was open due to COVID and constraints like that. So the 2 most common things we have noticed have been food insecurity and housing insecurity and rental issues. And one other thing has been developmental delays. because of people coming over from like other countries, war-torn countries. We've had a lot of Afghan refugees. So our organization does a lot of work with Afghan community. We recently had some Ukrainian refugees coming in. The whole process of them navigating the system here has been an experience for them, right? They've gone through some traumatic experiences, and they ask for, we need behavioral health. Can we talk to a therapist? Can we talk to a counselor? And as I mentioned before, we've had a huge national crisis or shortage of behavioral health clinicians at this time, especially for pediatric patients. And that's another one that we see a lot of in the adverse childhood experiences is the immigration-related trauma that we notice. And we've also had barriers or challenges with autism evaluation. We do not have a lot of specialists who can do this evaluation, although I suspect autism, and there is a long wait list to get them evaluated. And especially in families where they started out with like, just a language delay. We are a bilingual family. We did come from a war-torn country. We are just situating ourselves, trying to find a home, trying to find food. And by the time they keep an eye on like, wait a minute, he's not doing what he's supposed to do at this age, like age-appropriate developmental milestones are not being reached. That's when they bring them in, and we've had that barrier for about autism evaluation as well.
It sounds like you scaled remarkably quickly, which is amazing. What percentage of your well-child visits do you think that you're screening now for ACEs? If you had to guess.
Almost 100%, maybe like 90% above. In Santa Clara County too, we've had new clinical directors who are all pediatricians. Our medical director there is also a pediatrician.
Yes.
So they have made a smooth workflow now in all of our clinics. We have been screening all of the patients from 0 to 18 years of age for the adverse experiences in every single physical. And we're actually also screening for anxiety, depression, the PHQ-2 forms, the generalized anxiety disorder GAD forms. We also started SDOH, or social determinants of health forms. And we have My Chart available now. So we actually send the forms over through the tablet. They come in, they fill out the forms. And I think that's one of our objectives for this year from leadership, which we recently discussed in the senior management team meeting. Our COO, Olivia Deer, our Chief Medical Officer, Dr. Ramchandani, they were all talking about how we can do like electronically, how we can gather this data so that we can provide better resources for patients. So we are screening for those. We're also screening for ages and stages questionnaire, where we check for appropriate developmental milestones. We are checking for autism with the MCHAT questionnaire. Food insecurity, which we recently started this week. We have 2 questionnaires for those to see. Hunger as a vital sign is what we are considering, and doing that to provide food resources for our patients. So they might be missing a few here and there, but I think 95% or all of them are provided this questionnaire. So when you were asking before, like how did we start? I think front desk was the first step, where they are told, this is a questionnaire, this is for this age group. What do you need to give? How do you approach a patient? How do you inform them what they're filling out when you first give out the questionnaire? So this was a training given to the front desk.
How comfortable do you feel the front desk is in terms of sharing that explanation with families? Have you noticed that they are actually saying the explanation and explaining the screen? Or has there been a situation where families are simply handed the questionnaire? And I'm asking this because in a lot of clinics, there is a struggle. There's a bump in the road in terms of explaining why we're doing the questionnaire. And oftentimes the scores are 0 because the family is handed a piece of paper about really traumatic, hurtful events without a reason why this is important.
Initially, we were apprehensive how the parents would take it. But the front desk has done a fantastic job. It's as if they were waiting to be asked to jump into this, because front desk, although they are the first phase or the first connection with the patients when they first come into the clinic, they are not as clinically involved as the medical assistants and providers, right? So they were waiting for this opportunity. So when they were told how to explain this to the parents, they did a fantastic job. So that when I walk around during my rounds to go see at the front desk or, take a sneak peek, and all, they're doing really good. And parents are getting an idea why we are screening them. And initially, I was also very nervous as to how the parents would take it. Would they feel offended? Because we're asking all these really sensitive questions in their private life. But like I said, they were waiting to be asked. I have not had a single parent be upset about this. They easily fill out the questionnaires. They actually point out and show me if sometimes I have missed or quickly go through. Like I said, we are screening for a lot of things. So, they point out and say, do you have anything for it or so on? And after they come in a few times and they have filled out these questions, like I said, in the first 3 years, we give it to them at first month, second month, fourth month, 6th month. By 6 months, they're aware. They need to come early. They need to fill out all these questionnaires and ask. They not only are asking me medical questions, they also ask me the other social questions or cultural nuances, like certain other questions that are not exactly there as a question on first questionnaire, but very related to it. And like you said, this is a very traumatic experience for them. And sometimes they have to relive it while they are filling out these forms over and over again. So what else we are doing is what's called the positive experiences, talking about what are their positive strengths before we end the visit. Although we are not doing the hope or the positive questionnaire at this time, which I learned from Ken Epstein, one of your coaches and guides, he spoke about it several times in the Resilient Beginnings Network sessions that we had throughout from the second year onwards. Because the parents are already filling out so many questionnaires, we did not add another questionnaire. But the way we as pediatricians and the providers are ending a visit is talking about the positive strengths and which can bring resilience to our families. For example, when they say, I'm going through depression, anxiety. For example, the teenagers, when they talk about the COVID lockdown pandemic, how we were feeling, there was no social connections, not able to meet friends and so on. But then they're speaking to a therapist, their parents are involved, they're trying to involve them in board games or something. Every evening I talk about, look at the positives you have in life. So I ended with a positive message or a note to pointing out their strengths, like you are seeing a therapist, your family is here to support you. You came in today to talk about this. So these are all your positive strengths and we are going in the right direction.
You have to balance the adversity with the resilience and the hope framework. It sounds like that's what you're using a lot of. And I think that's really awesome.
Indeed. Yeah.
You've been part of the Resilient Beginnings Network for the last 3 years. What are you most proud of?
I think collaborating with various team members. That's what I'm proud of. So I have met up with so many team members like Melissa and other medical assistants who have played different types of roles in this collaboration, from front desk to our providers, to new hires. When they come in and I say, this is what the trainings you need to do, they're ready. So the enthusiasm that they all have to provide for our patients the resources that they need, from screening to healing, is great. And in this process, I have met so many wonderful leaders and role models, and gotten guidance from the Resilient Beginnings Network and learned from other community organizations who were involved in this learning. I still remember Dr. Suzanne Frank from School-Based Clinics of Santa Clara. She was far ahead of the curve. She had already screened and had the resources ready. She was doing the positive experiences screening. And for example, when she talked about what's called no-hit zone, where no adult shall hit another child, no adult shall hit a child, no child shall hit an adult and no child, she'll hit another child. So we sometimes see in some of our patients, like when I'm talking to the mom and she goes, hey, wow, don't do that, or so on. I'm like, oh no, look, these are the gentle parenting techniques and this is how we do it, and so on. So the amount of learning I've had and how everybody else is open to learning on our team and the connections I have made through this has been a proud moment.
Do you have advice for other clinics who are earlier on in their trauma-informed journey or haven't yet started ACEs screening and response? What would you like them to know?
I think we should just get started. We were very apprehensive to start with. And like I talked about, a lot of administrative barriers or the process barriers, workflow barriers. What do we do when we have positive ACEs? So there are a lot of what ifs, and assumptions that this won't go well, or, we are not set up for success and so on. I think we should get started and baby steps will lead us there. And we are all learning.
Always learning. That's for sure. In the spirit of always learning, what are the next steps for you all?
We would like to have a dedicated pediatric care coordinator like Melissa in all of our clinics, or more of her in our clinics. We do have 4 big pediatric clinics here in, they're family medicine clinics, but we have pediatrics in it as well here in Alameda County, and 4 big ones in Santa Clara County. And she's the only one for us at Alameda County. So we are trying to replicate the work she's doing by hiring another care coordinator for Santa Clara County. I think that's our first one. And the second one is expanding the screening to pregnant women. I recently spoke with the transgender and HIV team manager to perform the screening in that population. When we had the senior management team meeting, she was talking about how her population are so much more affected, has 10 times more ACEs than the general population. And I think that's the next direction that we're going to go with, to expand the ACEs screening with those. Also, to expand them for adults, which is once in a lifetime. But if we need, so we can always do it at every visit if we want to. But that's what they say, once in a lifetime for adults. And of course, hire bilingual, especially Spanish and Mandarin speaking behavioral health clinicians, especially to our south, to provide access to more patients in their language of preference, which has been challenging. So we are constantly on the lookout for recruiting these behavioral health clinicians.
I heard you all say that there are 40 providers at Bay Area Community Health. That's a lot of providers for one care coordinator. How do you balance that?
It's a little challenge, especially because I'm new in the role too. I try to, balance, do, a little bit of, follow of my, positive ACEs, like I do my follow-ups on my ABA referrals. So I do, a little bit of, each, every day as I go. And, I could only do, like what I can do in a day, but I try to balance by doing a little bit of each. So I don't leave, my ACEs, positive ACEs behind. And, also, the parents, they don't stay also without hearing from us to see what's going on with the referrals. So I do a little bit of, of each, in a day.
A little bit is a lot, I think. The little bit that she does is a lot because I was talking about the CHCN Pediatric Care Coordinator pilot grant. They asked us to write the number of minutes she spends on each patient for data purposes. So we've been using smart forms, smart touches, like where she writes about it. It gathers the data, how many minutes she spends with the patient. That just shows how many minutes she's saving for us, for the providers, and how that's preventing burnout for us, which I don't think she's seeing. But that's my perspective to this.
So how many minutes was it?
She spends about 45 minutes to an hour per patient, 30 to 60 minutes per patient.
That's a lot.
It's depending like on the screenings too, right? I mean, a lot of families, they like to speak. I've gotten feedback like, they're happy that they have someone to speak to, like they have vent out to me, with a lot of things. And, I'm here to hear them out, like I support them, I always, offer them any resources they need. But these calls can take up to 45 to an hour sometimes. And, like I said, that's what we're here to hear them out and support them. And, it's been a challenge, but I mean, we're here. That's what we're here, the care coordinator to help out and, just offer them resources and, whatever they need.
Can you share a case in a de-identified fashion, of course, where you felt as if you made a big impact on a family?
So I had a patient, I think it was one of my first patients when I was doing my first ACE screenings, and there was an aunt that I had called for the screening, and she mentioned that the parents had passed away of the child. Also, their grandma passed away right after the parents, and the aunt had to take over the child, right? Like she was a guardian now, and it was hard for her, because she was an elderly age, and these children were young. And, now these, children stay without a mom, without a dad, and without a grandmother. So now the aunt had to lead, and, it was tough for her. And, she was just happy that she was able, to express everything to me, talk to me, and then offer the resources, that she needed. So, I mean, she was very, glad that she was able to talk to someone. And, this happened, her story happened in Mexico. So she had to bring the children to the United States. So she was she became the guardian. So it was touching, just hearing, it's just, we get an impact, right, of all these patients, the stories that they tell us. So, I mean, like I said, we're here to support. We're here to support all the parents and the guardians.
I'm confident that you made a huge impact on her life. So thank you for the work that you do. It's really important.
Thank you for embarking on this episode of Health Pilots, hosted by the Center for Care Innovations with podcast production services by Wayfair Recording Company. Special thanks to Dr. Dana Long, the Resilient Beginnings team at CCI, Trauma Transformed, and the featured pediatric care team that has joined us today. Check out this episode's show notes for relevant links, resources, and opportunities. And if you like what you heard, please spread the word. We're available on all major platforms, and be sure to subscribe where you listen to podcasts. For more information about the Center for Care Innovations, or for upcoming programming, events, and funding opportunities, please visit our website, careinnovations.org, and connect with us on our socials, LinkedIn, Facebook, and Twitter. This is Wes Cabrillo at the Center for Care Innovations, and we appreciate you tuning in. Catch you on the next episode of Health Pilots.